Well, good morning to you. I am Dr. Nilesh Gautam, Senior Interventional Cardiologist, PD Hinduja Hospital, Mumbai. We are going to talk about a very important topic today, role of ARNI, that is angiotensin receptor neprilysin inhibitor in heart failure patient. Large number of our patients today present to us with heart failure, and this is a subset of patients which we see in our day-to-day practice. It is increasing the number of these patients in leaps and bounds. What's more important is that we have new drugs in our armamentarium today, and the overall prognosis, morbidity, mortality, MACE events, sudden cardiac death, repeat hospitalization due to improper treatment all have reduced. So what are these drugs? And the pillar stone or the cornerstone for the treatment of heart failure patients today is one, the beta blockers, two, they were ACE or ARBs and now the ARNIs, three, mineralocorticoid receptor antagonists, and four, the SGLT2 inhibitors. So the important point which needs to be addressed today is that should we shift all our patients with heart failure and reduced EF who are on ACE to ARNI? When to switch? Should we start them on an ACE or an ARB, monitor them, and switch over to an ARNI at a later date? How that soon that later date should be? Should we wait till they become unstable, then only add? So these are very important questions which need to be addressed, right? And let's try and see. So the illusion of stability in heart failure, right? Stable, what is stable? So 20% of stable patients with no prior heart failure hospitalization, as was seen in the paradigm heart failure, had a primary event. 17% of them died during the course of the clinical trial, the so-called stable patients. Or stable patient who experienced a primary event, death preceded heart failure hospitalization in 51% of the patients. Means half the number of patients, right, died before heart failure hospitalization or before they could be hospitalized. And so this is a huge number, and 60% of these deaths were due to sudden cardiac death. So it's an illusion that heart failure patient is stable. No, he is not stable. ARNI should be initiated as early as possible. Do not wait till deterioration occurs. Debate closed. The 2017 ACCHA guidelines and the 2022 ACCHA update for the management of heart failure has recommended that level of evidence is A. Class 1 recommendation that patients of heart failure with reduced EF and NYHA class symptom 2 to 3, the use of ARNI is recommended to reduce morbidity, mortality. Class of recommendation 1, level of evidence E, means massive data backing the early long-term use of ARNI in all patients in whom it can be tolerated, right? So is acute decompensated heart failure different from de novo heart failure? Do we say so? Means is it really so? So let's come to what is de novo, naive, or first time detected patient of heart failure. The patient characteristic is that he does not have any history of heart failure. Whereas an acute decompensated heart failure patient, it may be a primary index event or an already chronic heart failure patient who has known underlying heart disease now has come with worsening heart failure. So naturally in these group of patients, there are multiple comorbidities. That is acute decompensated chronic heart failure patient like IHD, COPD, AF, diabetes, stroke, TIA, past history of a CABG or PCI. That means some revascularization has occurred. Whereas in de novo heart failure, it's less frequent. Trigger events are more common in the form that poor medication compliance, there is resistance to treatment, super added infection, excessive salt intake, dietary irregularities, cardiovascular complication in the term of fresh event, ischemic episode, or an arrhythmia, or drugs like alcohol and digitalis. De novo heart failure, cardiac ischemia or valvular incompetence, that is acute myocardial infarction, acute mitral regurgitation, inflammatory, that is viral myocarditis, and now COVID, we've seen in the last 2 years, and toxic drug induced insults. The clinical presentation usually in an acute decompensated patient is dyspnea, orthopnea, lower limb edema, ascites, weight gain, whereas a de novo patient, there is cardiogenic shock and pulmonary edema. So the main pathophysiological derangement in acute decompensated chronic heart failure patients is pulmonary and systemic vascular congestion, which is caused by LV dysfunction, maladaptive neurohumoral activation, or fluid overload and redistribution. Whereas in de novo patient, it is acute hemodynamic derangement, which is caused by LV dysfunction. So it's important to understand this,